Welcome to AI Medical School. Our new subject is clinical medicine, and this is the first class of it, infectious diseases. But before we start, if you haven't subscribed to my channel, so please subscribe to it and press the like button to motivate me to make more video for you. So let's start. Infectious diseases. Infection remains the main cause of morbidity and mortality in humans, particularly in developing areas, where it is associated with poverty and overcrowding. Although the prevalence of the infectious disease has reduced in the developing world as a result of increasing prosperity, immunization and antibiotic availability, antibiotic-resistant strains of microorganisms and diseases such as human immunodeficiency virus, HIV, infection have emerged. Increasing global mobility and climate change have aided the spread of infectious disease worldwide. In the elderly and immunocompromised, the presentation of infectious disease may be atypical, with few localizing signs, and the normal physiological responses to infection, fever and sometimes neutrophilia, may be diminished or absent. A high index of suspicion is required in these populations. Common investigations in infectious disease. Blood tests. Full blood count, erythrocyte sedimentation rate and C-reactive protein, biochemical profile, urea and electrolytes and liver function testing. Imaging. X-ray, ultrasound, echocardiography, computed tomography and magnetic resonance imaging are used to identify and localize infections. Positron emission tomography and single photon emission computed tomography have proved useful in localizing infection, especially when combined with CT. Biopsy or aspiration of tissue for microbiological examination may also be facilitated by ultrasound or CT guidance. Radionuclide scanning after injection of indium or technetium-labeled white cells, previously harvested from the patient, may occasionally help to localize infection. It is most effective when the peripheral white cell count is raised and is of particular value in localizing occult abscesses. Microbiological investigations. Microscopy and culture of blood, urine, cerebrospinal fluid and feces should be performed as clinically indicated. Immunodiagnostic tests. These detect either a viral or bacterial antigen using a polyvalent antiserum, a monoclonal antibody or the serological response to infection. Nucleic acid detection. Nucleic acid probes can be used to detect pathogen-specific nucleic acids in body fluids or tissue. The utility of this approach has been enhanced by amplification techniques, such as the polymerase chain reaction, PCR, which increases the amount of target DNA or RNA in the sample to be tested. Pyrexia of unknown origin. Pyrexia, or fever of unknown origin, is defined as a documented fever persisting for more than 2 weeks, with no clear diagnosis despite intelligent and intensive investigation. Occult infection remains the most common cause in adults. Causes of pyrexia of unknown origin. In this table, you can see the causative agents which cause pyrexia or fever. Investigations. A detailed history and examination are essential, and the examination should be repeated on a regular basis in case new signs appear. First-line investigations are usually repeated as the results may have changed since the tests were first performed. Full blood count, including a differential WCC and blood film, ESR and CRP, serum urea and electrolytes, liver biochemistry and blood glucose. Blood cultures, several sets from different sites at different times. Microscopy and culture of urine, sputum and feces. HIV testing, chest X-ray, serum rheumatoid factor and anti-nuclear antibody. Second-line investigations are performed in conditions that remain undiagnosed and when repeat physical examination is unhelpful. Abdominal imaging with ultrasound, CT or MRI to detect occult abscesses and malignancy. Echocardiography for infective endocarditis. Biopsy of liver and bone marrow occasionally. Temporal artery biopsy should be considered in the elderly. Management. The treatment is of the underlying cause. Blind antibiotic therapy should not be given unless the patient is very unwell. In a few patients, no diagnosis is reached after thorough investigation, and in most of these the fever will resolve on follow-up. That's it for now. I hope you like it. Thanks for watching, and don't forget to press subscribe button.